Welcome back to the deep dive. And a very special welcome back to our Drug of the Week series.
Great to be back.
We're definitely back at full strength, ready to help you really master pharmacology essentials.
Yeah, getting into the nitty-gritty.
Exactly. So whether you're a nursing student, pharmacy student, med student, you know the drill. These are quick hit deep dives. We pull out those must-know details for your exams and, just as importantly, for your clinical practice.
Absolutely. Theory to practice.
This week, the spotlight is on Fluconazole. You probably know the brand name, Fluconazole.
Oh yeah, definitely a common one.
It's an antifungal powerhouse. You're definitely going to see this both in school and out there on the wards or in the clinic.
No doubt about it.
So stick around, maybe grab something to take notes. Our mission, as always, is to pull out those key nuggets from the source material, give you that edge, that shortcut to being really well informed. Okay, let's unpack this important medication.
And it's worth saying, fluconazole, well, its broad utility, really changed the game for antifungal therapy.
Oh, so?
Well, before fluconazole, treating serious fungal infections often meant long hospital stays, IVs. It was tough. Fluconazole gave us this well-absorbed oral option for many of these infections. That was huge.
Ah, right. Huge for patient access, comfort.
Exactly. Comfort, outcomes, everything. It's kind of foundational now. Maybe we take it for granted a bit. But yeah, its impact was massive. A real game changer.
That's a perfect way to frame it.
That's
Really sets the stage. Okay, let's dig into the specifics then. One, the basics. What is fluconazole? So first things first, let's get our bearings. How do we classify fluconazole? What exactly is it?
Okay, so pharmacologically, it's in the azole class of drugs.
Azole, okay.
And therapeutically, we call it a systemic antifungal. And like you said, the common brand name is Flucan.
Yeah.
Just knowing it's an azole immediately tells us something. It gives us a clue about how it works, its mechanism.
Right, and maybe what kind of fungi it targets.
Exactly. These azoles generally go after the fungal cell membrane. 2, how it works. Mechanism of action and therapeutic effects.
Okay, so it targets the fungal cell membrane. How does it, actually do that? What's the mechanism?
So fluconazole works by inhibiting the synthesis of something called ergosterol.
Ergosterol.
Yeah, think of it like the cholesterol equivalent, but for fungi. It's absolutely essential for building and maintaining a healthy fungal cell membrane. By messing with its production, fluconazole basically makes the membrane weak, leaky. It cripples the fungus.
So it stops it from growing properly.
Right. The main effect we see is fungistatic. It stops the
What?
fungi from growing and replicating.
Okay, fungistatic.
But, and this is a key point, like level of detail for students, in higher concentrations, it can actually be fungicidal.
Ah, so it can kill the fungi too.
Yes, it can actively kill them at higher doses.
Does that fungistatic versus fungicidal difference matter much in practice?
Oh, absolutely.
Sure.
For someone generally healthy with, say, a superficial infection, fungistatic is often enough. Their immune system cleans up the rest.
Makes sense.
But if you have a patient who's severely immunocompromised, maybe undergoing chemo, or with advanced HIV, you often want that fungicidal effect to really wipe out the infection. So yeah, it influences our dosing and our goals. And it works against some important bugs like Cryptococcus neoformans and various Candida species.
The ones that cause a lot of common and sometimes serious infections.
Exactly. 3, what it treats, indications.
Okay, so given that mechanism, fungistatic, maybe fungicidal, where do we actually use fluconazole most? What are the key indications?
Well, what's really fascinating here is just how versatile it is. We use it for a surprisingly wide range of things, both PO and IV.
Like what?
Okay, so things like oropharyngeal or esophageal candidiasis, that's thrush, basically.
Thrush, common.
Very. But also more serious stuff. Systemic candidal infections, UTIs caused by candida, peritonitis, and even cryptococcal meningitis. That's a really serious fungal infection of the brain and spinal cord lining.
Wow, okay, so from thrush to meningitis, that's quite a range.
It is. And it's also used preventatively, like preventing candidiasis in high-risk patients, maybe after a bone marrow transplant.
Prophylaxis, yeah?
Yep. And then there's the really common one. A single oral dose for vaginal candidiasis. Yeast infections.
The famous single-dose pill.
That's the one. And there's even an unlabeled use off-label for preventing recurrent vaginal yeast infections. It can make a big difference for some people. 4, the journey through the body, pharmacokinetics.
So it treats a lot. How does the body actually handle it? What's its journey? The pharmacokinetics that lets it reach all these different spots.
Yeah, if we connect this to the bigger picture, fluconazole actually has pretty good pharmacokinetics going for it. Absorption-wise, it's absorbed really well when taken orally. That's a huge advantage, right?
Uh,
Patient convenience,
Definitely better than needing an IV if you don't have to.
for sure. And the distribution, it gets around widely in the body. This is key. It gets into places like the CSF cerebrospinal fluid really well.
Ah, okay. That CSF penetration explains the meningitis use.
Exactly. That's critical.
Yeah.
But it also gets into saliva, sputum, vaginal fluid, skin, the eye, peritoneum, pretty much everywhere.
Yeah.
That broad distribution is why it works for so many different types of infections.
Okay, gets everywhere. What about getting rid of it? Metabolism, excretion.
Right. So most of it, over 80%, is actually excreted unchanged by the kidneys.
Unchanged. So the kidneys just filter it out as is.
Pretty much. Less than 10% is metabolized by the liver. So it's mainly a kidney-cleared drug.
Okay, that sounds like a really important point. Renal excretion.
It absolutely is. Super important. It means you have to think about the patient's kidney function.
Because if the kidneys aren't working well.
The drug will build up. The half-life, which is normally around 30 hours in adults, gets much longer if there's renal impairment. So dose adjustments become absolutely critical to avoid toxicity. You also see differences based on age, longer in preemies, shorter in kids.
Got it. Kidney function is paramount here. 5. Timing is everything. Time action profile. Okay, so that 30-hour half-life, more or less. What does that mean for dosing frequency? How often do patients usually take it?
Well, the nice thing is that duration effect is about 24 hours for both the oral and the IV forms.
Ah, so once a day.
Exactly. It really simplifies things,
Hmm.
allows for convenient once daily dosing, which is, great for patient adherence.
Much easier to remember once a day.
Absolutely. Makes it more likely they'll finish the whole course, which you need for fungal infections.
And how quickly does it start working or reach peak levels?
For the oral form, peak levels are usually reached in about 2 to 4 hours. With the FARFI, it's basically peak levels right at the end of the infusion. 6. Who should be cautious? Contraindications and precautions.
All right, makes sense. Now, it sounds effective, but powerful drugs always come with risks. What about safety? Contraindications, precautions. Who needs to be careful?
Right. So the obvious one first.
Oh.
Anyone with a known hypersensitivity to fluconazole or any other oral antifungal shouldn't take it.
Okay, standard allergy stuff.
Yep. But here's a critical one.
Yeah.
You absolutely must avoid using it at the same time as pimozide, erythromycin, or quinidine.
Pimozide, erythromycin, quinidine. Why those specifically?
It's because of the risk of additive QT interval prolongation.
Ah, the QT interval. Can you quickly remind us why that's such a big deal?
Sure. The QT interval on an ECG reflects the time it takes for the heart's ventricles to repolarize, basically reset after beating. If that interval gets too long, it dramatically increases the risk of a very dangerous, potentially fatal heart rhythm called torsades de pointe.
Okay, torsades, not good.
Not good at all. So that interaction isn't just a suggestion, it's a critical safety warning. Don't use them together.
Got it. What else? Pregnancy.
Generally, yeah, contraindicated in pregnancy. But like many drugs, it might be considered for really severe life-threatening infections if the potential benefit to the mother outweighs the risk to the fetus. A tough call.
Always a risk-benefit calculation there.
Always. Then you use it cautiously in patients with renal impairment. We talked about that. Dose reduction needed if creatinine clearance is under 50. Also be cautious with underlying liver disease, structural heart disease, any electrolyte abnormalities, or if the patient is taking other drugs that can prolong the QT interval.
Stacking risks there.
Exactly. And watch out in older adults. They often have reduced kidney function just due to age, so they're at higher risk for adverse effects. 7. Potential pitfalls. Adverse reaction side effects.
Okay, so lots to be cautious about. Beyond those contraindications, what are the main side effects or adverse reactions we should be looking out for? The potential pitfalls.
Well, it's interesting. While a lot of the potential side effects are fairly mild, like maybe some GI upset,
Nausea, diarrhea, that kind of thing.
yeah, abdominal discomfort, nausea, vomiting, diarrhea, those can happen. But fluconazole also carries a risk for some really serious, potentially life-threatening problems. We already mentioned the big cardiovascular one, QT prolongation, and that risk of torsades de pointe.
Okay, number 1 cardiac risk.
Definitely. Then dermatologically, skin reactions.
Yep.
You need to be vigilant for severe reactions like Stevens-Johnson syndrome, SJS, or toxic epidermal necrolysis.
10. Those sound really bad.
They are. We're talking widespread blistering, skin peeling. These are medical emergencies, not just a simple rash. Immediate discontinuation needed.
Wow. Okay, SJ-Sin. What else?
Endocrinologically, there's a risk of adrenal insufficiency, high triglycerides, low potassium hypokalemia. GI-wise, besides the common stuff, there's the risk of hepatotoxicity. liver damage.
Liver damage. Okay. Monitoring LFTs then.
Absolutely critical.
Yeah.
Neurologically, maybe dizziness, headache, sometimes even seizures. And like many drugs, always the potential for hypersensitivity reactions, including anaphylaxis.
Right, the severe allergic reaction.
Exactly. So knowing these serious ones helps you monitor effectively and react quickly if they start showing up. 8. The interaction web. Drug interactions.
That's definitely a list of serious things to watch for. Now, let's tackle the interaction web. Fluconazole is kind of notorious for interacting with a lot of other drugs. How do we even begin to manage that?
Yeah, that interaction list is long, but if we connect it to the bigger picture, it's not just about memorizing a huge list. There's an underlying reason.
Okay.
Fluconazole is a potent inhibitor of certain liver enzymes, specifically some of the cytochrome P450 enzymes like CYP2C9 and CYP3A4.
Ah, the CYP enzymes, the drug metabolism workhorses.
Exactly. These enzymes break down tons of other medications. When fluconazole inhibits them, it basically slows down the metabolism of those other drugs. So their levels go up, and the risk of toxicity from those other drugs increases.
So it's more about understanding that mechanism, the CYP inhibition, than rattling off every single drug.
Precisely. That's
Yeah.
the key principle. Now, you still need to know the really critical ones. We already hammered the contraindicated ones.
Hmm.
Pimozide, erythromycin, quinidine, because of the Torsades risk. Don't use them together, period.
Got it. Contraindicated.
Then there's a whole bunch where fluconazole increases their levels. Think immunosuppressants like cyclosporin, tacrolimus, sirolimus, very important in transplant patients.
Right. Narrow therapeutic windows for those.
Exactly. Certain statins like atorvastatin, simvastatin, lovastatin, risk of muscle problems goes up. Oral hypoglycemics like glyburide, risk of low blood sugar increases.
Yeah.
Warfarin need to watch the INR much more closely for bleeding risk.
Okay, warfarin interaction is classic.
It is. Also increases levels of phenytoin, many benzodiazepines, some calcium channel blockers, methadone, certain antidepressants. The list goes on.
It's extensive.
It really is. And conversely, some drugs, like rifampin, can actually decrease fluconazole levels, making it less effective.
So it works both ways sometimes.
Can do. It just underscores how vital it is to do a thorough medication review, a drug interaction check, every single time you start or stop fluconazole, or any other drug for that matter. Use your resources, pharmacists, databases.
Absolutely crucial step. 9. How much and how often? Route dosage. Okay, so bearing that complex interaction profile in mind, let's circle back to dosing. How much fluconazole do people typically get, and how often? Especially factoring in things like kidney function.
Right, the dose really depends heavily on what you're treating, the patient's age, and like we stressed before, their kidney function. So for example, adult thrush might be 200 milligrams on day 1, then 100 milligrams daily for at least 2 weeks.
Okay.
But that single dose for vaginal candidiasis is usually just 150 milligrams orally, once.
Big difference.
Huge difference. And doses for kids, neonates, they're all carefully calculated based on weight, sometimes gestational age. But the most important clinical pearl here, the thing you absolutely have to remember, is adjusting for renal impairment.
Because it's kidney cleared.
Exactly. Because it's primarily renally excreted. If you don't reduce the dose in someone with poor kidney function, the drug builds up. That significantly increases the risk of toxicity, those adverse effects we talked about.
So what's a general guideline for adjusting the dose?
The standard recommendation is if the patient's creatinine clearance is 50 LAM or less, they should generally get 50% half of the usual dose.
Half the dose if CRCL is 50 or below.
Correct. And for patients on hemodialysis, they typically get a full dose after each dialysis session because dialysis removes the drug.
Yeah.
On the days they don't have dialysis, they might get a reduced dose. It just really highlights how you had to tailor the therapy based on individual physiology. 10. Ozelo. Availability.
That's super important dosing info. And just quickly, what forms does fluconazole actually come in? How is it supplied?
It's pretty convenient, actually. It comes in several forms. You've got tablets, 50, 100, 100, 150, and 200 milligram strengths.
Standard tablets.
Yep. Then there's a powder you mix up for an oral suspension, usually orange flavored, comes in 10 milligml and 40 milligml concentrations. Good for kids or people who can't swallow pills.
Okay, suspension too.
And for IV use, it comes already pre-mixed in bags, usually 100 milligrams and 50 millibels, 200 or 100 millibels, or 400 and 200 milliliters, typically mixed in 0.9% saline.
Ready to hang.
Exactly. So that range of options gives clinicians flexibility to choose the best route and dose for the situation. 11. Bringing it to the bedside. Nursing implications and patient teaching.
All right, that leads us right into the practical side, bringing fluconazole to the bedside. What are the key nursing implications, the assessment points, the patient teaching we really need to nail down?
Okay, this is where it all ties together, right? Assessment-wise, Always assess the infected area, obviously. Get cultures before starting therapy if possible, though treatment often starts empirically. Critically, monitor the patient for any rash, especially a severe one. If you suspect SJS or 10N widespread blistering, systemic symptoms, stop the drug immediately and notify the provider. That's an emergency.
Right. Monitor skin closely. What about labs?
Labs are key. Monitor BUN and serum creatinine for kidney function, especially if they're getting it long-term or have baseline kidney issues. And definitely monitor liver function tests, AST, ALT, alkaline phosphatase, bilirubin, because of that hepatotoxicity risk.
Okay, skin, kidneys, liver checks. What about actually giving the med?
Implementation pearls. First, a big safety one. Do not confuse Fluconazole, with Diprivan, Propofol. Sound alike, look alike potential there. Very different drugs.
Huge safety point. Diflucan versus Diprivan.
Massive. If giving orally, instruct patient to take it at the same time each day. Shake the suspension really well before each dose. For 4, infuse it over 1 to 2 hours. Don't push it fast. Maximum rate is usually 200 milligrams per hour. Maybe slower, like over 2 hours, for higher doses in kids.
Okay, slow infusion. Compatibility. Can it run with other IV meds?
Yeah, Y-site compatibility is actually pretty good with a lot of common ID meds, which is helpful. However, you absolutely must know the incompatibilities. Don't run it with amphotericin B, either deoxycholate or the lipid complex.
Okay, Ampho B is a no-go.
Definite no-go.
Yeah.
Also incompatible with ampicillin, dantrolene, diazepam, diazoxide, gemtuzumab, ozogamicin, pantoprazole, Protonix 4, and trimethoprim sulfamethoxazole, Bactrim 4.
That's a specific list to know.
It is. Always double-check compatibility before mixing anything in an IV line. A quick check prevents serious problems.
Absolutely. Okay, what about teaching the patient and their family? What do they need to know?
Patient teaching is crucial for adherence and safety. First, stress taking it exactly as directed, same time each day, and finish the entire course, even if they feel better. Fungal infections can come back if not fully treated.
Don't stop early.
Exactly. If they miss a dose, take it as soon as they remember, but don't double up the next dose. Warn them about potential dizziness or seizures, rare, but possible. Advise caution with driving or activities needing alertness until they know how it affects them.
Okay, driving warning.
Yep. And tell them to notify their doctor or nurse immediately if they develop a severe rash, abdominal pain, fever, or persistent diarrhea. Also, any signs of liver problems, fatigue, loss of appetite, nausea, vomiting, jaundice, yellow skinees, dark urine, pale stools, call right away.
Signs of liver toxicity. Got it.
Unusual bruising or bleeding too. And finally, the reproductive potential piece. Explain it may cause fetal harm. Effective contraception is needed during treatment and for 1 full week after the last dose. They must tell their provider if they are pregnant, planning pregnancy, or breastfeeding.
Comprehensive teaching points there.
Yeah.
12. What success looks like. Evaluation desired outcomes. Okay, so we've covered a lot. How do we know if the treatment is actually working? What are we evaluating? What does success look like with fluconazole?
Well, success fundamentally means we see a resolution of the signs and symptoms of the fungal infection, both clinically, what the patient feels, what we see, and in lab tests, if applicable, like cultures becoming negative. It's important to manage expectations, though. Remind patients that a full course might take weeks, sometimes months, especially for deeper infections, even after they start feeling better.
Right, it's not always a quick fix.
Not always. If it was used for prevention, like after a bone marrow transplant, then success is simply not developing candidiasis. And for something like vaginal candidiasis, success is seeing that decrease in irritation and discomfort. A little clinical tip here. If someone keeps getting recurrent vaginal yeast infections despite treatment, it's wise to reconfirm the diagnosis maybe with lab tests before just giving more fluconazole.
Why is that?
Because sometimes recurrent infections can be a sign of something else going on, like undiagnosed diabetes or an immune issue. Or maybe it's a resistant strain, needs a second look.
Okay, that makes perfect sense. So, wrapping this up, what does this all mean? We've really dug deep into fluconazole today. We've looked at its mechanism, how it works, the huge range of things it treats, those critical precautions and interactions, potential side effects, and the vital nursing and patient teaching points.
Yeah, covered a lot of ground.
We've definitely seen why it's called an antifungal powerhouse. Understanding all these details, these nuances, that's what's going to help you on exams, and more importantly, help you take better care of patients. It really sets you apart.
Absolutely. And maybe this raises an important question for you, the listener, to think about moving forward. Given how common fluconazole is and its really extensive drug interaction profile, especially that CYP enzyme inhibition, how can we as healthcare professionals get better at navigating polypharmacy, patients on multiple meds. How do we manage that complexity safely to ensure we get the best antifungal outcomes without causing harm from interactions?
That is an excellent question, a real challenge in modern medicine and something definitely worth pondering. Great final thought. Remember to check out our full Drug of the Week playlist for more deep dives like this one. They're designed to help you pass those boards and stay sharp in your practice. Thanks so much for joining us on this deep dive into fluconazole.
Yeah, thanks for tuning in.
We'll catch you next time.